Welcome to part 2 of the Elimination video lecture for NUR PNR 180. We're going to continue with our GI dysfunction, talking about obstructive disorders for the GI. In particular, we're talking about hypertrophic pyloric stenosis and intussusception. Hypertrophic pyloric stenosis is a constriction of the pyloric sphincter with obstruction of the gastric outlet. So what happens with hypertrophic pyloric stenosis? That circular muscle of the pylorus, it thickens, causing a narrowing of the pyloric canal between the stomach and the duodenum. They don't know what the cause is. It's not well known. It is believed to be a genetic predisposition, and it's more common in firstborn males and full-term babies. How do we diagnose? It's based on history and physical, the child's clinical manifestation, an ultrasound and an upper GI x-ray may be done to confirm, and the clinical presentation of someone with hypertrophic pyloric stenosis. They will present with projectile vomiting. It usually occurs 30 to 60 minutes after eating, weight loss, because they're not getting the nutrition they need, dehydration, distended abdomen. The infant will appear hungry and accepts feeding after vomiting. After a certain amount of time, they may demonstrate a failure to thrive. The symptoms actually may occur 4 to 6 weeks after birth. So they'll seem like they're feeding normally and everything's going well. And at 4 to 6 weeks after birth, the symptoms will start to show. So this is what it looks like with someone with pyloric stenosis. Here, the circular muscle around the pylorus the pyloric sphincter is enlarged, causing a constriction. Therefore, the material is being trapped in the stomach and eventually accumulating enough with peristalsis from the stomach will push the contents out, causing projectile vomiting. After surgery, they loosen up that muscle. Therefore, the sphincter can open up, allowing the contents to go into the duodenum. Therapeutic management. Surgical repair is performed, and it's called a pylorotomy. The success rate from surgery is very high. Nursing care preoperatively, we want to prioritize to keep the fluid and electrolyte balance within normal range, and they do that with IV therapy. They will put the infant on NPO, which is nothing by mouth. An NG tube may be in place for gastric lavage, which means letting the fluids from the contents from the stomach, removing them. Post-operative care has the same focus. It is not uncommon for the infant to experience vomiting post-operatively for the first 24 to 48 hours. An NG tube may be in place for varying amounts of time. The feedings will begin soon after surgery with clear liquids containing sugar and electrolytes. It's offered slowly and at frequent intervals. Milk is introduced once clear liquids are tolerated well. The positioning of the infant during and after feeding should be with the head elevated. Care of the operative site. You want to make sure that you inspect the surgical incision for signs of infection. And then you want to also encourage familial involvement with the care. Intussusception. Intussusception is a type of bowel obstruction where it is telescoping or invagination of one portion of the intestines into another. It occasionally can result from an intestinal lesion, but oftentimes the cause is unknown. This is what it typically looks like when someone has intussusception. It usually happens at the ileocecal area of the colon, at the large and small intestines. And you see that the larger intestines has telescoped into the smaller intestines, eventually causing swelling and a obstruction. Clinical manifestations. You will see a child who has sudden acute abdominal pain followed by periods of comfort. So the child will be screaming and draw their knees to their chest area, and you wonder what's going on, and then several minutes later, they might be fine or appear fine. As it progresses, you will start to see vomiting. They will start to present with lethargy. They will start to pass what looks like red currant jelly-like stools. So it's blood in the stools and mucus, and so it looks like a red currant. Tender, distended abdomen. They also will have a palpable sausage-like mass, typically in the right upper quadrant. There will be an empty lower right quadrant. That's called the dance sign. And there's eventual fever, prostration, and other signs of peritonitis. How do we diagnose intussusception? Based on a history and physical and the clinical manifestations, abdominal x-ray, and a barium enema. How do we treat? It's usually medical. Oftentimes the diagnostic tool, the barium enema, will correct the invagination of the intestines back to its original place. The doctors now are also utilizing water-soluble contrast or air to reduce an intussusception. If medical treatment is not effective, then surgery will be done. The prognosis, it's good. Serious complications are uncommon. That once they correct it, they're usually fine after that. Occasionally people will have relapses or have a tendency to have that in their childhood if they do have it once, but the correction usually takes place and the person does not suffer from serious complications. The nursing considerations are related to whether there's surgery requirement or not. The next we're going to talk about is malabsorption disorder or celiac disease. Celiac disease, also known as gluten-induced enteropathy and celiac sprue. So you'll hear that if someone says this person's suffering from gluten-induced enteropathy or celiac sprue, it is the same as celiac disease. The 4 characteristics that you will see with someone with celiac disease is steatorrhea, which is fat in the stool, general malnutrition, abdominal distension, and secondary vitamin deficiencies. Celiac disease and related health supervision. Celiac disease is found in the proximal small intestines. The person has a permanent intolerance to gluten, which is found in wheat, barley, rye, and oats. The physicians or parents find symptoms several months after the introduction of gluten-containing solids into the child's diet. So what happens with celiacs? If you look here, you'll see that these are normal villi in the stomach where absorption of nutrients can take place. And someone who has been exposed to celiacs, or has celiacs, the villi shrink, thus decreasing the absorption of nutrients. Diagnosis and treatment is based on signs and symptoms. We do IgA, AGA blood test, a biopsy of the small intestines, which demonstrates characteristic changes of mucosal inflammation and villus atrophy. The treatment is dietary, avoidance of food containing gluten. Nursing considerations, teaching and guiding the family is essential. The treatment is mainly dietary and requires lifelong adherence. Reading labels on all food items is necessary. Complications may include growth retardation, anemia, osteomalacia, and certain malignancies. One of the websites that I frequently visit, and this is actually a Canadian website, but it has a lot of great information about celiac disease, is www.celiac.ca. Thanks for listening, and if you have any questions or concerns, please feel free to email me.